Hi, and welcome to the next session in the Radiology Snapshot series. So this time we are going to focus on head CTs and some spine radiology, and this should hopefully cover everything you need to know for your OSCEs. So to start with, we're just going to briefly cover different stroke classifications, and this is one of the more common classifications used, so it's the Oxfordshire Community Stroke Project classification. And in this one, you classify them based on where the injury has occurred and the clinical features. So it's a really helpful table to learn and really impressive if you can identify this and state this in your OSCE, and we will show you some examples of different strokes next. But before we look at the strokes, we're just going to have a quick look at the brain blood supply, as this can help orientate yourself to the different symptoms and the different areas of the brain that could be affected by different infarcts. So Teach Me Anatomy is a really useful resource, and here we can see the different areas on the left supplied by the different arteries, and on the right is the circle of Willis. So this can help you to appreciate how there might be some preserved function in some strokes or some blockages due to alternate routes of blood supply. Again, circle of Willis, so really important to consider this and to consider the different presentations that it could lead to. So if we start now by looking at ischemic strokes, so these are commonly due to a embolism or a thrombus and are associated with some conditions like diabetes, cardiovascular, so atrial fibrillation. And you have varying different degrees of changes shown on the CT scan depending on how soon the stroke occurred. So sometimes it can appear as just a normal CT scan. However, it can also be sorted into early hyperacute, which is within 0 to 6 hours, late hyperacute, which is 6 to 24, acute, which is 24 hours to 1 week, subacute, which is 1 week to 3 weeks, and chronic, which is more than 3 weeks. And this is a lot to cover in a 10-minute session, so I would really advise following the link at the bottom of the slide and going to Radiopedia, as they have a really helpful YouTube video on that site which will help to explain some of the changes you can see. The other type of stroke that you can have is a hemorrhagic stroke, and this can be classified into primary and secondary. So primary when there is no underlying cause, and secondary when there is an underlying cause. So an example of a secondary cause, which is quite common, could be an aneurysm or a perianeurysm, and this could have burst or ruptured, leading to a hemorrhage within the brain. Once again, Radiopedia features a really useful YouTube video on their website, so if you follow the link below, this will give you some more information on the changes you can see, as strokes in general are very complicated and there's a lot that can be gained from a CT scan. And for OSCEs, you just need to be able to quickly identify what the problem is and your treatment plan moving on from there. However, if you're looking into more detail and you want to properly report on these types of scans, then would really recommend reviewing those YouTube videos. So now we're going to move on and briefly discuss the types of hematomas that you can have. So you can have extradural or epidural, as it's described on the table, and subdural. And really important, as these have different mechanisms of injury and different vessels involved. So your extradural is your middle meningeal artery, whereas your subdural is your bridging veins, and these will give you different presentations on a CT scan. So here we can see an example of an extradural hemorrhage, and this is commonly called a lemon shape. So as you can see, there's large white lemon-shaped bleed, and this is obviously showing up more white on the CT scan in this example. In comparison to a subdural CT hemorrhage injury, which, as you can see, looks more like a crescent shape, and it's really important to be able to identify these, as they may have differing treatment plans or differing symptoms on presentation. The third and potentially more serious type of injury that you may see is a subarachnoid hemorrhage. And commonly you will need to get an MRI scan for this, as it is slightly more sensitive, although CT is normally the primary imaging of choice. So these typically present with your thunderclap headache. So it's a very typical, very classic presentation that really should not be missed. Often patients will have associated genetic disorders or connective tissue disorders such as Marfan's and Ehlers-Danlos, which might put them at increased risk. Other risk factors include your hypertension, family history and alcohol consumption. Additional symptoms may be photophobia or meningism, and commonly there can be loss of consciousness followed by regained consciousness, which might falsely reassure you. So really important to make sure that you maintain good monitoring of these patients. Another presentation that you might see on a head CT is that of a space occupying lesion, and this can either be a brain tumour as in the image on the left or a hemorrhage as in the image on the right. And these can affect other structures within the brain, obviously putting more pressure and having a mass effect. They can also lead to midline shift, which we will have a look at on the next slide, which can be potentially serious and will need urgent senior review. And in terms of brain tumours themselves, the World Health Organization have released a classification for all CNS tumours. There are many different types and they have many different instances within them. They are seen more frequently in adults, although there are some paediatric presentations that differ from adults as well, so it is worth reviewing that. So now we're just briefly going to discuss midline shift, as I mentioned earlier. So this can be due to a space occupying lesion or tumour, or any of the hemorrhages we have discussed previously. And this is most commonly due to raised intracranial pressure. So you measure the shift in millimetres, and the midline is assumed to be in the same position as the falx cerebri, although some care has to be taken as some patients may have a midline that differs to this. And this can potentially be viewed and measured on previous images, if any exist. So the final head case that we are going to look at is that of hydrocephalus, and these can be classified into obstructive and communicating. So the image on the left is showing an obstructive case, and the image on the right is showing a communicating case. And you can commonly see and identify these due to changes in the ventricle system within the brain, and these will require senior follow-up and senior input to manage. So now if we move on to the spine, we can have a look at spinal fractures. So you can see an example of a cervical fracture, a thoracic fracture and a lumbar fracture moving from left to right. So these can be very complex injury and can cause impingement or damage to the spinal cord, so it can also present with neurological symptoms. Commonly these can be due to trauma, although there could be some underlying pathology such as osteoporosis which affects these injuries. Obviously the symptoms and signs that you may see will depend on where in the vertebral column you have obtained the injury, and they can also be classified according to the type of fracture and where the fracture occurs within the vertebrae. So these will require spinal surgery input and probably an MDT approach. I briefly mentioned that you can classify them based on where the fracture has occurred, so the different levels. You can actually name the level, so for example if there was a C5 injury you could say C5 fracture, and then also depending on where in the vertebral body and the vertebral level has been damaged. So it could be the spine's process, it could be the lamina, the pedicles, etc. So again, this is another way to classify these injuries. And our final case is that of a disc prolapse. So as you can see, there is some impingement in both of these images. And this can occur due to old age changes within the disc or acquired sporting injuries. And these will have varying presentations depending on, again, where in the spinal column is affected. So most commonly this is in the lumbar spine around the L4, L5 level due to the increase in pressure that goes through that area of the spine. So these are just some of the references we used to create this teaching session for you, and please do go back and review some of the links that I mentioned. Thank you very much for listening. Sorry that it was a very whistle-stop tour. Hope you enjoyed it and hope to see you on the next session.